8 EKG patterns we cannot afford to miss. These patterns in the right clinical context are suggestive of acute coronary occlusions and require immediate reperfusion therapy without any delay. It's our responsibility to identify these EKG patterns early and save the patient's lives. The cardiologist is not always available to interpret EKGs for us. Knowing and memorizing these patterns is key to recognizing them. If you find it difficult to identify these EKG changes, don't worry, I have a solution for you later in this video. But before we start, let's review some important facts about acute coronary syndrome. Acute coronary syndrome is a dynamic process in which the coronary artery may spontaneously open and close. This causes alternating periods of symptoms and symptom-free intervals with corresponding changes, of course, on the EKG. This is why obtaining serial EKGs is important for accurate diagnosis and monitoring. Remember, symptoms and EKG changes provide a real-time snapshot of ongoing myocardial ischemia, while troponin levels may initially be negative as they typically rise 2 to 3 hours after symptoms onset. EKG changes in acute coronary syndrome can range from subtle to obvious. Take a look at this picture that I borrowed from Dr. Smith's ECG blog. When an acute coronary occlusion occurs, a hyperacute T-wave develops within minutes to hours, followed by ST elevation, followed by the development of a pathological Q waves if prompt reperfusion therapy is not provided. If reperfusion is achieved, T-wave inversions develops. Now, this is very important. Not all patients must develop this sequence of EKG changes. Many with acute coronary occlusions may develop hyperacute T-waves without ST elevation at all. This is why there is an increasing trend challenging the STEMI versus NSTEMI paradigm and replacing it with occlusion versus non-occlusion MI instead, as this will lead to prompt and appropriate reperfusion therapy if there are any EKG signs of acute coronary occlusion. Before we continue, if you would like to receive a summary of this video, kindly subscribe to my Substack page. The link is provided below. Let's start with the first EKG pattern. This is an EKG from a 54-year-old diabetic lady who presented with chest pain. As you see, the EKG is showing ST elevation in the inferior leads with reciprocal depression in AVL. This is the STEMI pattern, which is probably the most obvious one in today's patterns. And according to the American College of Cardiology, to call it a STEMI, you must have the criteria showing here. Of course, our patient met these criteria and the cath lab was immediately activated. The patient had 100% RCA occlusion that was opened and stented. How about this EKG from a 60-year-old lady with a history of coronary artery disease and a stent to the LAD who presented with chest pain and shortness of breath? As you see, the EKG is showing normal sinus rhythm, axis is to the left, normal intervals, LVH with high AVL voltage, Q waves in V1, 2, 3, and hyperacute T waves in V2 and V3, along with ST elevation that do not meet the STEMI criteria we just mentioned. This is an acute occlusion anterior MI, anterior wall MI, despite not meeting the official STEMI definition. Unfortunately, this was not picked as an acute occlusion MI because of that. Later, the first troponin came back positive and the patient was admitted as NSTEMI. She was treated medically with antiplatelets and heparin drip. The next day, she went into cardiac arrest, was resuscitated, and underwent emergent left heart cath, which showed 100% instant restenosis of the proximal LAD. Unfortunately, she had another cardiac arrest and died shortly after that. We must recognize the hyperacute T-waves pattern. Hyperacute T-waves are the earliest signs of acute coronary occlusion, and they do not necessarily evolve into ST elevation as we mentioned earlier. How about this EKG obtained from a 75-year-old man after he collapsed to the ground in cardiac arrest while shopping with his wife? He was successfully shocked out of VFib and brought to the emergency department. This EKG shows a deadly sign called shark's fin sign, which is a combination of QRS and T waves. There is a massive ST elevation in inferior leads, reciprocal depressions in lead 1 and AVL, and ST depressions in precordial leads, maximum at V2, 3 through V4. The patient has an acute inferior posterior occlusion MI. These changes are not due to hyperkalemia. In this case, the cath lab was activated, but there was a pushback from cardiology as they thought these changes are due to hyperkalemia, despite the potassium level came back as normal. Eventually, the patient was taken to the cath lab, found to have 100% RC occlusion. He went into cardiac arrest, unfortunately, during the procedure and could not be resuscitated. So please remember this deadly shark fin pattern. How about this EKG from a 7-year-old man who presented with chest pain? The ST depression in precordial leads V1 through 4 catches my eye immediately, and it's more prominent in V3 and 4. This is the posterior wall MI pattern that we must recognize. These anterior leads are reciprocal to posterior leads. You may want to record posterior leads to confirm, although it's not necessary. Remember, the ST elevation in posterior leads will be subtle if you do posterior leads, since these leads are further from the heart and must penetrate through the electrically insulating air of the lungs. Now, we must activate the cath lab when we recognize the posterior wall MI pattern. How about this EKG from a 30-something-year-old patient with chest pain? Of course, I'm immediately drawn here into those hyperacute T-waves in anterior leads, but notice here that these hyperacute T-waves are preceded by ST depression with an upsloping ST segment. This is an important distinction from the posterior MI pattern, where there is an ST depression in the anterior lead but not the distinctive upsloping ST segment of this fat and bulky hyperacute T waves. This is what we call the De Winter EKG pattern that's indicative of acute LAD occlusion or near occlusion. We must recognize the De Winter pattern and activate the cath lab immediately. This patient was found to have 100% LAD occlusion. How about this EKG from a 43-year-old gentleman who had 2 episodes of chest pain, which prompted him to come to the ED for further evaluation. He was chest pain free when the EKG that you just see here was recorded. The EKG shows normal sinus rhythm, access to the left. There may be LVH based on the voltage in AVL, T-wave inversion in precordial leads, and if you look closer, you will see the inversion is in the latter part of the T-wave, or what we call terminal T-wave inversions. Remember, in acute coronary syndrome, T-wave inversion is a sign of reperfusion. These are Wellens waves or Wellens syndrome, which indicates spontaneous reperfusion of acute LAD occlusion with a very high risk of free occlusion. It's crucial to recognize this pattern and activate the cath lab. Now remember, to call T-wave inversion Wellens waves, they must meet the following criteria. There is resolved anginal chest pain. Remember, these are reperfusion waves and they happen in the LAD territory, which means the anterior and sometimes the lateral leads. There is preserved R waves and no Q waves in these leads, and there is no LVH in the involved leads. This can cause pseudo-Wellens waves. Now, I have another EKG. Here's the patient EKG when the patient was having active chest pain. We see here hyperacute T waves in anterior leads and ST elevation in V2 and V3 and 4. The patient was taken to the cath lab and a near total occlusion of LAD with a thrombus was found and stented. The next AM, another EKG was obtained, and we see the Wellens waves now deeper and almost symmetric. This is what we call pattern B Wellens T waves. Pattern A is the terminal T wave inversion we described earlier that is typically seen soon after reperfusion, which almost always evolves into type B, the Wellens, the deep symmetric T waves inversion. So always think of Wellens when you see T wave inversions in somebody who presented with chest pain that has resolved and the EKG obtained while chest pain free. How about this EKG from an 85-year-old with a history of hypertension who developed chest pain and collapsed and had a bystander CPR? The EKG is showing complete left bundle branch block with wide QRS, a monophasic R wave in lateral leads, and a predominant negative QRS in anterior leads. As you know, left bundle branch block produces secondary ST changes. The ST deviation is in the direction opposite that of major deflection of the QRS, and it is proportional to the amplitude of the QRS complex, which is called appropriate discordance. This means we will have a discordant non-ischemic ST elevation in leads V1, 2, 3, and 4 in left bundle branch block. This ST elevation must be proportional to the size of QRS complex. Excessive discordant ST elevation or any degree of concordant ST elevation is suggestive of acute occlusion MI in the appropriate clinical context. Now, it's easy to identify concordant ST elevation, but how do we tell if there is an excessive discordant ST elevation? Here we use something called modified Sgarbossa criteria, which uses the ratio of ST elevation at the J point to the preceding S wave. Any ratio higher than 0.25 is highly specific for occlusion MI. Take a look at this image. The ratio in A is less than 0.25 while more than 0.25 in B. In B, it's called discordant ST elevation. Let's apply the modified Sgarbossa criteria to our EKG, and we can see disproportionately discordant ST elevation in V4. The ratio between ST elevation and the preceding S wave is 0.33, and this is very specific to occlusion MI. There is also a concordant ST elevation in lead 3 and V5. In lead 3 and V5, the QRS is isoelectric, and so the ST segment should be isoelectric. Instead, it's slightly elevated. This patient was taken to the cath lab after initial resistance from the cardiologist and was found to have a 100% mid-LAD occlusion and 90 to 95% RCA occlusion. The same criteria can be applied to right ventricular pace rhythm. Let's have one more. How about this EKG from a 50-something-year-old woman who complained of acute chest pain radiating to her left arm while driving. She was brought to the ED, and as you see in the EKG obtained, there is subtle ST elevation in lead 3 and reciprocal depression in ABL. This suggests inferior occlusion MI despite the absence of the full STEMI criteria. This is another reminder that the STEMI criteria can inappropriately exclude some patients from immediate reperfusion therapy when it's mostly needed. If you see such a pattern in the right clinical context, activate the cath lab. But why there is no ST elevation in other inferior leads? There is only in lead 3, there is none in 2 or AVF. It's because there is a diffuse ST depression, if you see in this EKG, in most other leads with the reciprocal ST elevation AVR. The ST depression vector is going toward lead 2 and AVF, which cancels the ST elevation forces in these leads, while lead 3 is far to the right away from the ST depression vector. Now, the presence of diffuse ST depression that's maximum in V4 to V6 raises suspicion of what we call diffuse subendocardial ischemia. If there were no inferior occlusion MI, the ST segment in lead 3 would also be depressed. Now, think of diffuse subendocardial ischemia whenever you see diffuse ST depression in 7 or more than 7 leads with ST elevation in lead AVR. Diffuse subendocardial ischemia can be due to decreased supply from severe coronary artery disease due to left main disease, proximal LAD, and or severe 2 or 3 vessel disease, or from increased demands as we see in tachycardia, or from other arrhythmias, from shock, profound hypotension, GI bleeds, sepsis, etc. Now, why don't we consider this a posterior wall MI pattern? In a posterior wall MI, ST depression is typically localized, whereas in diffuse subendocardial ischemia, as you see here, is diffuse or widespread. Additionally, in the posterior wall MI pattern, the maximum ST depression is seen in leads V2, 3 to 4, while in diffuse subendocardial ischemia, it's most pronounced in leads V4, 5, and 6. Now, this pattern of inferior occlusion MI and diffuse subendocardial ischemia is called the Aslanger or Aslanger pattern, which means inferior occlusion MI with ST elevation lead 3 only and reciprocal ST depression AVL, and diffuse subendocardial ischemia where there is ST depression in 1, 2, V3 to V6 with reciprocal ST elevation in AVR. To conclude, only the STEMI pattern meets the official STEMI criteria in our examples, while the posterior wall MI and D-Winter patterns are considered STEMI equivalents. There should be no hesitation from cardiology in activating cath lab for these cases. The remaining 5 patterns, the Hyperacute T-wave pattern, shark fin patterns, Wellens T-wave, invergence pattern, Aslanger pattern, and left bundle branch block meeting the modified Sgarbossa criteria, may sometimes face resistance from some cardiologists when considering activating the cath lab. However, it's crucial to advocate for the patients when these findings are present to ensure they receive timely intervention. In the end, recognizing these patterns saves patients' lives. The best way to recognizing them is to know and memorize these patterns. Remember, EKG interpretation is about recognizing patterns. For the time being, if you struggle with that, I highly recommend you request access for the PM Cardio app. Its use is still investigational and it uses AI to identify all occlusion MI patterns. It was developed by some of the gurus of EKG and acute MI, including Dr. Stephen Smith, whom I highly recommend you follow his blog, where he posted hundreds of cases and still posting continuously. And from his blog, I borrowed most of these cases under Common Creative License. Links to the app and the blog are provided below. If you would like to receive a summary of this video, kindly subscribe to my Substack page. The link is provided below. If you find this video useful, please give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. Thanks for watching, and I'll see you soon.